Welcome to AETCM, the Emergency Medicine Channel. 56-year-old female came to ER with alleged history of RTA, scooter vs car on 5th February, followed by she fell on her left side with a hit her chest on road, followed by complaining of pain over the left side of chest and shoulder.
Okay. Yeah.
On initial 10-second assessment, patient was conscious and oriented. On primary survey, airway, C-spine, secured with Philadelphia collar. Then there is no stridor, no hoarseness of voice. On breathing part, saturation was maintained 96 on room air, respiratory rate 18. Oscillation part decreased air entry on left parabasal area. On circulation part, heart rate is 82, BP is 130, 50 millimeter mercury, and there is no any deformity. What GCS is 15/15, pupils bilateral equal reactive right. This is the primary survey. On pain score, she complaining of 8/10 pain. We give injection PCM 1 gram IV stats. An adjunct to primary survey, we do a E-fast. E-fast is positive. Left side mild pleural effusion is noted in E-fast on 12 p.m. of that same date. Then chest X-ray also we done. Chest X-ray showing rib fractures of left side 3 to 9 rib fractures, and effusion also in the left side. ABG. ABG was pH 7.3, PO2 95, PCO2 32, bicarbonate is 27.
Okay. So that's the primary survey and your adjuncts to the primary survey. Okay. So you have a lady who was a pillion rider. So she was
pillion rider.
She was pillion rider, and she had a fall on her chest, and she has developed left-sided lower chest, abdominal, lower chest and abdominal pain. No, only lower chest.
Shoulder and left chest tenderness.
Left chest tenderness, and she has been brought to the ED. ABC was stable. But she had a decreased air entry on the left lower zone. That's what you said. And you had done an E-fast and you were showing a mild pleural effusion.
Pleural fluid effusion.
So in trauma, what do you will call that one? When you're seeing something fluid in trauma, what do you call that? It's hemothorax. It's hemothorax. It's unless and until blood, it is blood. So it is hemothorax what you're seeing there. So it's not pleural effusion. It is hemothorax. And what was the lung sliding?
Lung sliding, that area it is no lung sliding.
So it's a hemopneumothorax. Basically a hemopneumothorax on the left side. And okay, fine. Then next you have done an X-ray and it was showing a fracture of 3 to 9. 3 to 9, whether it was a flail or just a fracture.
No sir, fracture only.
Only
suppression, there is no suppression.
There is no separation. There is no flail chest. There is only fracture on that affected side. Okay. And again there was hemothorax. Hemothorax with pneumothorax. Hemopneumothorax. So that's what you had seen. And you have given paracetamol for the pain. So what is the other injury that you will suspect in this lady? With the mechanism of pain, mechanism of injury, what are the possible injuries that you will suspect in her?
One is rib fracture, chest injury, like a blend causes splenic injury.
Most importantly, lower rib fractures, you have to think in terms of a splenic injury also. So her abdominal fast was negative. There was no free fluid. So when will you repeat a fast again?
After 2 hours.
When you will do a repeat fast in a patient with trauma? When initial fast is positive, no need to repeat it. When initial fast is negative, when will you repeat a E-fast or whatever be it? Whenever there is a hemodynamic instability, whenever there is a vital change, you have to reassess. Multiple times you need to repeatedly reassess. This is not like 2 hours, maybe after 15 minutes, maybe after 30 minutes. You need to repeatedly review the patient by doing a fast. Unless and until you are ruling it out, if it has become positive, you don't need to do. But if it has become negative, you need to repeatedly and rapidly, multiple times you need to do. Then, so there is no splenic injury initially. So what was done for her?
Initially, there is no desaturation or there is vitals are stable also. BP wise, it is there is no tachycardia, no hypotension. there is no tachypnea.
My question is whether this patient require an ICD right now or not needed.
Normally we put ICD in hemothorax. We put ICD. There is massive hemothorax patients.
We need to put an ICD. That is very clear. This patient is not just a simple pneumothorax, it's a hemopneumothorax. We definitely need to put an ICD initially. That is very clearly, we need to go ahead and put an ICD because there is blood also getting accumulated. We don't know the quantity of blood. So we have to put an ICD. So that is for sure. So we have to put an ICD and see how much amount of blood is drained. Why that is important?
If there is more than 200 ml per 2 to 4 hours is draining, we do emergency thoracotomy.
If initially itself you are getting like 1500 or 2000 ml of blood, you are draining, then that is a massive hemothorax. Then that is an indication for your exploratory thoracotomy. Okay. So 1500 or you are getting 2 liters of fluid. Or after inserting an ICD, if you are getting like 150 to 200 ml of blood being drained in every hour for the next 2 hours, that also is an indication for an emergency thoracotomy. So when you are suspecting a hemopneumothorax, you need to put an ICD. There is no doubt you need to put it initially itself. But when you are suspecting only a pneumothorax, maybe a subtle pneumothorax, very minimal pneumothorax, maybe you can wait and watch. But whenever it is hemopneumo, you have to put an ICD. So that is the first thing. So he needs this lady requires an ICD. We need not wait her for to deteriorate till she desaturates or till goes for a hypotension. So that is one thing. So that is one point. So who all requires an ICD in the ED?
With
Traumatic. I am just putting trauma.
Traumatic, sir. Tension pneumothorax.
Okay.
With
you have to do an initial needle decompression followed by an ICD placement. ICD. Okay.
Open pneumothorax patients. Anyway.
Open pneumothorax. Okay.
Then after that we could.
Initially you do a 3-way adhesive bandage. On following that you need to put an ICD. Where will you put ICD for an open pneumothorax patient?
Just lateral to the injury.
My question: we have got an open pneumothorax in the 4th intercostal space. The patient has come with an open pneumothorax in the 4th intercostal space. A stab injury was done and this knife was removed. So you have clearly seeing an open wound and somebody have put a tape and it's a clean incised wound. So where you will put an ICD for that patient?
Anyway, the wound not used for ICD putting, so lateral to that wound.
4th intercostal space. I am saying it is in the 4th intercostal space. It's a 5 centimeter long wound.
The same wound we doesn't put ICDs.
So where else you will put the ICD?
5th intercostal.
You can put it in the 5th intercostal space. That is the most important thing. The same space should not be used to put your ICD, even if it is in your anatomical landmark. So what is the anatomical landmark for your ICD?
ICD is a safety triangle, that is 5th intercostal space, mid-axillary line, lateral to the pectoralis major, anterior to the latissimus dorsi.
That all muscle you will see. What you will have to do in our ED? That's simple. Anterior axillary fold, posterior axillary fold. You are able to elicit yes. Base of the 5th rib you are able to do in the axilla. Yes. So that's your triangle. That's your triangle. Then where you will put in the triangle? You draw a line anterior to the mid-axillary line is the area where you put an ICD. So what are your prerequisites for inserting an ICD? What are the different techniques for putting an ICD? What are the prerequisites for putting an ICD? What size you will select? My question here, what is the size of your ICD tube that you will select? What are the different methods by which you can do an ICD insertion?
For pneumothorax, we will take 20 to 24 gauge chest tubes because small tube is needed for air to enter. In hemothorax, we take larger tube like...
That was a concept. Now itself, if they are saying hemothorax also, you can take like 28 French and also the acceptable. Like before and all, 32, 36 was recommended. Now also 28 French is reasonably acceptable. Unless and until you are able to drain the blood, that is okay.
Then connect to monitor, consent, local anesthetics like lignocaine, needle, tube, chlorhexidine, gauze,
blade, underwater seal. Then positioning the patient.
Positioning a patient, supine position and arm must be rest on the head, below the head.
Maybe you can take like 30 to 45 degree, little bit anteriorly rather than patient lying down flat. Maybe you can 30 to 40 degree upright, you can keep the patient so that your triangle, everything will be visible very clearly, and you can able to get enough space when you are extending your heads up, the intercostal space become more and more clear. So that is the reason. And then you can go with two methods, like you're putting an incision and you can use either a trocar, using it with a trocar, or you can use your the routine dissection. You are going and dissecting, and you are finding the pleura and putting an incision. Then you are inserting your ICD tube. So what we practice is our trocar method commonly, but some surgeons prefer to use the old surgical method where they are dissecting each muscles and they are cutting muscles and going and incising in the pleura and putting an ICD. So it has got benefit, and for a beginner it might be easy to use a trocar. But again, trocar, the problem is that if you are not very clear, you are holding the trocar like a hold stick like this. You should never hold it like this. Should never hold your trocar like this. If you are holding your trocar, you are going and directly puncturing. What will happen? The whole length can go inside. So always make sure when you are inserting a trocar, for example, this is your trocar, you make a guard like 2 to 3 centimeter. You make a guard with your hand. Guard with your hand. So only that much you are inserting initially. So otherwise, if you are holding the trocar below, what is the problem will happen? You don't have any control. So maybe 10 centimeter can go inside and it can cause BPF and it can penetrate further. So always make it a point, you make a guard in around 2 to 3 centimeter like this, and then you keep your trocar and then you push, so that you are very sure that you are not penetrating further. So that is the one advantage of this. But you are not trained to hold a trocar, don't go with the trocar method. Go with the routine incision method where you are dissecting each layer by layer. Then you are seeing the pleura. Then you will get the giveaway. Then you insert your ICD and you drain off the air. Again, in the trocar method, the problem is that there will be multiple openings in the trocar. So when you are not putting all the openings inside the pleural cavity, one will be lying outside. So again, air can get sucked in. So that is again one important thing. That can happen for the other one also. So whenever you are inserting this method, you make sure that all the holes are inside and secure it properly. And also you look at the how much amount of blood that is getting drained, and always make it a routine practice that you are getting a chest x-ray after that, or maybe you can get an ultrasound and see what the position, but always get a chest x-ray. So left side ICD, you have to be a little bit more careful because cardiac structures are there. Maybe it's a large hemopneumothorax, it will be easy, but when it's a small one, you have to be a little bit more careful. So the triangle of safety holds good. On the right side, you have got the liver. On the left side, you have got the chest. So you have to be very careful when you are putting an ICD. But if when you go for the triangle of safety, that is why it is called as triangle of safety. But when you are using the trocar method, this is one thing that I want, because none of the books gives you this tip. Always hold it like 2 to 3 centimeter near to that, then you insert. So you will not go beyond that. So if it is not inserted, then you can make 1 more centimeter and you can push till you are reaching the pleura. So you are getting that gush of air when you are puncturing the pleura, that will come. So that you have to keep in your mind. Okay, then. So that is regarding your ICD. So what are the common life-threatening injuries that you need to anticipate in ED? Life-threatening chest injuries.
Chest injuries like tension pneumothorax.
Okay.
Open pneumothorax. Tracheobronchial injuries.
Okay.
Traumatic cardiac arrest.
So traumatic cardiac arrest. Since you said regarding traumatic cardiac arrest, let's discuss traumatic cardiac arrest. It's very common to have a traumatic cardiac arrest coming to the ED. So how will you manage a traumatic cardiac arrest?
First of all, we check to find the cause of traumatic cardiac arrest. If tension pneumothorax, we will manage with the ICD. If cardiac tamponade.
So what is the basic concept of a traumatic cardiac arrest? What are the things that you need to do in case of a traumatic cardiac arrest? You are very sure that it's a trauma that is related to cardiac arrest, and you are seeing the patient has been brought in PA, or PA, we are okay, we have got some time, but the patient might brought in asystole, which has poor outcome. So we have confirmed that it's a traumatic cardiac arrest. You have started your resuscitation, but still the patient is not reaching ROC. So what will you do next?
Causes of this cardiac arrest.
What are the most important causes of traumatic cardiac arrest?
Cardiac tamponade, tension pneumothorax.
We are discussing regarding chest injuries. Okay. So tension pneumothorax and cardiac tamponade. Okay. Then. So what will you do next?
Tension pneumothorax, immediately put an ICD.
Needle decompression followed by ICD insertion. But when you have doubt, one side is not, both side you have to put an ICD. Bilaterally you decompress the chest. That is the first thing. Then look for pericardiocentesis, the pericardial fluid or for cardiac tamponade. Then still the patient is not improving. Still the patient is in cardiac arrest. Ideally, what should be done next? You are given fluids, you are looking for the reversible causes, you are hemorrhagic shock being the first topmost in the list. Then you have ICD tension pneumothorax, you have placed the ICD, you have looked for your pericardial fluid and you have drained some amount, but still the patient is not improving. That is the time when you will think of what? ED, emergency room, thoracotomy. So ED thoracotomy. So that is one, you don't need to shift the patient to the OT for a thoracotomy. So ED thoracotomy may be very rare in India, but abroad and all, basic major trauma centers, they used to perform ED thoracotomy. It is not very common in our country, but ED thoracotomy is one thing that you need to remember, and that is the ideal thing that you need to do in case of a traumatic cardiac arrest. Unless and until you have done all the required thing, you have decompressed the lungs by putting an ICD, you have given the fluid resuscitation, but again, penetrating injuries and all, we don't want to give a over fluid to the patient, because again, balance resuscitation, you don't want the clot to be dislodged and again the hypotension to worsen. So when you think of ED thoracotomy, when you have a traumatic cardiac arrest with either a penetrating or a blunt abdominal trauma to the chest, and you have done your initial management, but still the ROC has not been achieved. So that is the thing you have to remember regarding ED thoracotomy. There are two methods, anterolateral approach and clamshell approach. There are two things that you can read it upon. But one thing that you need to remember is ED thoracotomy. What we are trying to do, we are trying to look to the heart, whether there is any rupture that has happened to the heart, whether anything can be done for suturing or any bleeding can be stopped. The next thing what you are looking, we can directly give a cardiac massage to the heart. So that is the ED thoracotomy. 4% is what they have said the survival rate following ED thoracotomy, 4%. And there are some centers claiming to have very good rate of success also. So not in this patient I am saying, but the same patient, if she goes into a cardiac arrest, then that time you need to think why she is developing cardiac arrest. Even after chest decompression, pericardiocentesis is not improving. You have to think about ED thoracotomy. At least maybe down the year, maybe the trauma surgery, everything improves in our country. Maybe 10 to 15 years, we might see doing an ED thoracotomy also. So again, what all requirements for an ED thoracotomy itself is a topic. So we need to listen what are the things needed. There are separate equipment, because we have to do a sternotomy. Laterally, you have to retract the ribs and all, and we need to go. Looks little bit gross here, but that's what you need to do in ED. You have to intubate the patient. Definitely, you would have intubated in case of a cardiac arrest. That is a prerequisite. Then you need to get all your equipments, and you need to go ahead and do it. Think about ED thoracotomy. So just for the conclusion's sake, I have added thoracic traumatic cardiac arrest. So what was done for this lady?
ICD was done.
ICD was done. When was the ICD done?
Patient desaturated.
So we should not have waited for to that long. You could have placed an ICD earlier itself. So whenever it's a hemopneumo, don't wait. And again, one thing that I feel it is, whenever it is a trauma-related pneumothorax, almost always requires an ICD. Trauma-related. Maybe a spontaneous pneumothorax and all might come out without an ICD, but almost a traumatic pneumothorax, they requires an ICD. So that's what, even if it is a subtle one, they will have pain. There are rib fractures are there, they can go and cause further and the pneumothorax can get expand, and always that requires an ICD placement. Now once you have done an ICD placement, and what are the challenges for this patient? What are the major challenges for this patient?
ICD, if there is, after 1 week.
How much amount of blood was drained?
800 ml.
800 ml of blood. So it is not a massive pneumothorax. The major challenges will be pain management. Because of rib fracture, they will have significant pain. Because of the pain, what will happen? They will never move that area, and there will be a lot of atelectasis, and maybe there can be underlying lung collapse. So as a result, they can have secondary infections. So that is one most important thing in fracture is pain management. So what are the options for your pain management in this patient? IV analgesics we routinely give. So what are the other options that you can think of?
Opioids.
Epidural
analgesics.
Epidural analgesia. That is again one good thing that you need to think of. maybe multiple fractures like this patient, because of the pain they will not be moving, and as a result atelectasis and all those things happen. So epidural analgesia is one, and patient control analgesia, they can control how much analgesics they require. Maybe that is one group of patient. Intercostal nerve blockade is technically is not possible because multiple nerve roots are getting involved. So intercostal nerve blockade might be a difficult task. So if it's like 2 or 3 ribs, then you can think of doing that. And another thing is that
block,
serratus anterior nerve blocks that can be done. And stellate ganglion blockade, it will work. No, not in here. It will work where? Refractory. Recently discussed. So it will not help in this case. But one thing is that you have to think about pain management. Either epidural is a very good option because multiple fractures are there. Rather than doing a block which has got a effect for some time only, epidural maybe next 24 to 48 hours they can be pain free. And also you have got a lot of patches that is available. We use routinely in our ICU, maybe a buprenorphine patch or all, you can apply to that so that they will not have pain. So the without pain only they will start breathing. And lung rehabilitation is another biggest challenge. So without a proper lung rehabilitation, they will come back with you with multiple, they will have a pneumonia, they will have atelectasis. So a lot of issues they will have. That is the next challenge that we will be facing. So what we need to understand in our ED or whichever ED when you are managing thoracic injuries, don't just think about the thoracic structures alone, just the lungs and the heart, which we commonly think. Greater vessels and esophagus is also there. So depending upon the mechanism of injury and what are the type of injury, you need to think about that also. You have anything else that been done to this patient now? How is the patient now after the ICD? ICD has been removed or she has been
removed and discharged.
She has been discharged home. Then anything else that you want to add? Any key points that we have missed in the discussion? You have prepared and come, so it will be effective. Anything a bit? Nothing. Okay, fine. Thank you.
Thanks.